Okay, so 5 seconds to pause the video, and then we'll go through the answer. Okay, so we have a 57-year-old male coming to the emergency department for a dry cough and shortness of breath. He states that over the past 7 years, he has experienced mild shortness of breath with continued physical exertion. However, over the past week, he has suddenly become short of breath at rest. He has a past medical history of poorly controlled hypertension, hyperlipidemia. The patient also admits to a 30-year smoking history. He's afebrile. Blood pressure is 102/64, slightly tachycardic, 92% oxygen on room air. That might have something to do with this. Auscultation of the heart reveals an S3 heart sound. Usually when you see this, you're going to be thinking about more of a fluid overloaded state. So right when I see S3, I'm immediately starting to think about fluid overload state. And I can't help but see this massive image here where I see diffuse pulmonary edema bilaterally. Okay, diffuse pulmonary edema in both lungs. So that goes hand in hand with what we're seeing. That might explain why the patient's oxygen saturation is 92%. There's a faint systolic decrescendo murmur in the axillary region. That's interesting. So, when you think about mitral regurgitation, usually described as a holosystolic, high-pitched blowing murmur. Okay, that's usually how mitral regurgitation is described. However, axillary region tells me that this is probably going to be mitral valve. And the fact that this patient has an S3, they're fluid overloaded, right? Normally you'd be thinking about either mitral stenosis or mitral regurgitation. Because if you either have blood coming back from the left ventricle into the left atrium, or if you can't get the blood out of the left atrium because of stenosis, that blood is going to back up and eventually get into the lungs. As it backs up from the left ventricle to the left atrium, it's eventually going to back up and all that fluid is going to sit in the lung. So pulmonary edema would be a classic finding of left heart failure or a new onset or acute onset mitral stenosis or mitral regurgitation. Now, if it's a chronic mitral regurgitation, usually you'll see the holosystolic murmur, but early on, it might just be a very faint murmur. And the fact that it's systolic tells me that it's probably not mitral stenosis. Okay, remember, mitral stenosis is one of two diastolic murmurs that are really big to know. Mitral stenosis and the other one being aortic regurgitation. Okay, so lung auscultation is significant for diffuse crackles. No surprise there. Look at the lungs here. There is dullness to percussion over the lung fields. Remember, dullness is very classically associated with fluid in the lungs, which is what we're seeing here. This pulmonary edema, chest radiography has shown which of the following is most consistent with this patient's presentation. Well, what's happening in this patient? Well, we have blood that's going back from the left ventricle into the left atrium. Most likely it's probably, a new onset mitral regurgitation. And why I say that is because this patient just developed these symptoms over the past week. Yes, the patient had some very mild shortness of breath, possibly related to the smoking history, but all of a sudden, the sudden increase in shortness of breath at rest, see that something on the left side of the heart is most likely causing this patient's pulmonary edema. If the blood is flowing back because we have something like a mitral regurgitation happening here, maybe an acute mitral regurgitation, the systolic pressures actually are going to come down in the aorta because a lot of this blood is going to be reverting back to the left atrium. So we're most likely going to see a lower pressure in the aorta. Okay, let's look at left atrial pressure. So is it going to be depressed? Well, no, right? Because all this blood is going to be going from the left ventricle back into the left atrium. It's going to cause this left atrium to bulge. And remember what we talked about in the previous videos, just to plug it in here. If I have a really large left atrium, that can cause cardiovascular dysphagia, compress on the esophagus, compress on the recurrent laryngeal nerve, cause hoarseness, right? Those would all be very classic. So again, depressed left atrial pressure, probably not, okay? Probably not in this patient. And this is evidenced by the fact that we have this S3 heart sound, an axillary heart murmur in systole, right? And a very acute onset of the symptoms here, or say subacute in some ways. It happened in the past week, okay, in the setting of this pulmonary edema. Very likely that the left atrial pressure is going to be elevated. Okay, how about depressed pulmonary venous pressure? So again, the concept is we're regurgitating blood, right, from the left ventricle back to the left atrium. That blood's going to get backed up into the pulmonary veins, backed up into the lungs. And so all of these locations are really going to have higher pressures in general because they're accommodating more volume. When it gets back to the lungs, these pulmonary capillaries are going to be accommodating a lot of blood, and that's going to cause a higher hydrostatic pressure, causing this pulmonary edema. So I would expect the pressure to be higher in the pulmonary venous side, and the left ventricular diastolic volume usually is going to be elevated because it has to accommodate more blood from the pulmonary veins and blood from the regurgitation that's happening from mitral regurgitation. And so for those reasons, the left ventricular end diastolic pressure should be elevated. So the correct answer here is going to be elevated pulmonary capillary wedge pressure, which, if you didn't even look at some of these other options, I think this is one of those questions where you can kind of get to it pretty quickly. You just have to remember that the pulmonary capillary wedge pressure is associated with the left atrial pressure. So remember, the PCWP mean approximation of the left atrial pressure. And we already said that the left atrial pressure is probably going to be elevated in this patient because of the regurgitation of blood from the left ventricle into the left atrium. And again, you can see that here with all of this pulmonary edema. There's definitely a backflow of pressure that's happening on the left side of the heart that's making its way over to the lungs. So we would expect the pulmonary capillary wedge pressure to likely be elevated as it's synonymous with the left atrial pressure.